And there we go, we are. Hello, Elise Dallas, my gorgeous one. Welcome. And today we are tackling the topic of my favorite thing, vagina, as we know. And I forgot actually to get my other thing here, but I do have my, I've got my earstring.
Good. I've got my, where is it? There you go.
Excellent. Brilliant. We've got things going on here all over the place. So let us talk for a moment about what is it that actually happens to people's vaginas as they go through perimenopause and menopause? What's going on there?
Okay, so what's really happening, as we know, with menopause is that your estrogen is fluctuating, but gradually it goes down and down until you're not producing it anymore from the ovaries, hence menopause, and you've not had a period then for a year. But leading up to that, as we know now, perimenopause, so the years leading up to that, that's when you'll see the changes in, lots of, hot flushes, brain fog. But one of the ones is in your vagina and bladder, because there are lots and lots of estrogen and testosterone receptors. So at the moment, when you have estrogen, it has many different roles, but in the vagina, it looks after your vagina. It looks after the tissues around the bladder. I think if we think of it as three particular things that it does, the vagina, it makes it stretchy and elastic, so it can accommodate sexual intercourse. It also affects it at a cellular level, and it's responsible for lubrication, so and increasing lubrication when you become sexually active. And all of those together, it maintains a proper pH, so it keeps it slightly acidic, and that's what keeps out infection. So when that estrogen goes down and testosterone goes down, then you can start to basically have the opposite of what it's doing to protect it. So if you lose the estrogen, your vagina tissue becomes thin. It's not elastic. It loses collagen. If you think of prepubescent children, or what your vagina was like, well, you probably can't remember, but before puberty, I see a lot of pediatrics in my work, but little girls' vaginas are dry, they're thin, they pick up a lot of infections, and so that's what it goes back to being. So when you lose estrogen, it becomes thin, dry. The cells stop producing that lubrication which protect it, so the mucosal surface is lost, and the acid, so the pH changes, and therefore it becomes prone to infections. And that's not just in the vagina, it's in the bladder and the urethra and all of those organs within the pelvis.
Yeah. So and it's interesting because you mentioned vaginal dryness, but you said that often when patients come to you, it's not necessarily the dryness that is worrying them. So what are they coming to you and what are they saying? Or what are you trying to get out of them?
Yeah, and I think this is a really, really good point, because even as a clinician, I assumed, and we were kind of taught that, well, first of all, that the word, it's now called GSM, genitourinary symptoms of menopause. It used to be called senile vagina.
Senile vagina.
And then after that, and before this, it was vulval vaginal atrophy, which is drying up. Again, didn't mention the urethra, the bladder. So GSM is a better term, but again, it's something that not really people associate themselves with. And as a clinician, we're taught, because there's architectural changes, and when I say architectural, I mean changes in what the vagina looks like later on in the menopause, so postmenopausally, those changes happening. We assume that those symptoms should then go along at the later stages of being postmenopausal. But what actually happens is, leading up to that, you may experience symptoms. And when you say something, often when I say, oh, do you have a dry vagina? Do you have pain during sex? Of course, there's symptoms of it, but people often don't associate that themselves having these symptoms. So then I start asking, okay, well, if we break it down, genitos, so your genitals, are they sore? Are they itchy? Does it feel like razor blades? Often people think it's like, oh, it's literally hot and fiery between my legs. Or are you getting recurrent thrush-like conditions where you're trying the thrush creams, it's not just not working. It's a real burning pain. And if you're trying to do a desk job and you're sitting down, then, you know, it is quite uncomfortable. And then, so genito, that's your genital symptoms. If you do the urinary, so urgency, frequency, we know it can cause overactive bladder, which is meaning I'm getting up in the night, I'm needing to go more than usual. And people just think this is a urine problem and it's got nothing to do with my vagina and it's got nothing to do with menopause. And again, bacteria flourish. So are you getting a urine infection? Lots of people will get a feeling of urine infection, and actually there's no infection there at all. Or you could go to the doctors and there is a urine infection because it's more susceptible to infections. And then there's the sexual symptoms. So are you having discomfort during sex? Some people haven't had sex for months and months and months because of this. Or some people say, no, it's all right with a bit of lubrication. But often it's also about anatomy. People often don't know what their anatomy is down there. They're still not sure of the difference between so when you say, oh, we've got a dry vagina, they haven't, some people aren't sexually active. And so they haven't really thought about it. But when you put it to them, oh, is your vulva a little bit itchy? And often you can say, so in the early stages, and I know this actually happened to me, is that there is a big dip in estrogen. So all this is caused is by low estrogen and testosterone. But essentially that can be, even when you're not perimenopausal, it can be when you've just had a baby and you're breastfeeding. That's another time when you might get these symptoms.
Yes,
Also,
they've just come up with a new thing, the genitourinary syndrome of lactation.
I know, you were telling me this is brilliant because because it is a common symptom when you're breastfeeding. It's also a common symptom. And like I was saying, this happened to me probably in a year or two before my period started spacing out. But a day or two before my period would start, because you've got a real drop in estrogen, it would feel like I had thrush. And you mentioned that to people, and they're like, oh, yeah, I know it's related to my hormones. I thought it was, but because it was always at the same time of the month. But, kept getting thrush creams. And
that's what I did for 4 years or so. And
so
the psychological side to this as well. I mean, I don't know, maybe it's just me and my vanity, but I remember somebody at one stage saying to me, you should get some Avestin, you should get some sort of, topical estrogen cream. And, I was thinking, I don't need that. There's nothing wrong with China. After having like 4 years of repeated thrush, and literally when you say that it's uncomfortable, it's beyond. When it gets to that point, this is I know a lot of people have heard this before, but just in case you haven't, I could barely sit, I could barely walk. I could not have sex. Every time I did go for a walk, and I like to exercise and walk, I'd literally have to duck behind a tree somewhere and rearrange my labia. It wasn't necessarily the vagina that was the problem, but it was the outside tissues with constant burning, constant itching. It was hell.
Yeah, no, I completely agree. And like I said, my personal experience was this 1 or 2 days before my period. I mean, I'm now on HRT and I've now been doing this trial of vaginal estrogen, so it's completely gone. But I remember thinking, my God, if this is what someone has for the next 30 years of their life, and we've got to remember
every day,
progressive, and it only gets worse. It's not like hot flushes, which may be for maybe 7 years or something, and then you might stop having them. There are a few people that have them for the next 30 years, but that's quite unusual. Whereas this actually gets worse and it's chronic. And the other thing that I wanted to bring up is that when people bring up I don't know if you've heard the term of interstitial cystitis. So this is where someone they feel like they've got a urine infection. They feel it burning. They go and get it tested with the doctor. By then, they've probably been put on antibiotics because they assume it's their cystitis. But the urine come back completely clear, and it keeps coming back. And this can happen when you're on. I know, I'm not saying who, but a close family member of mine used to get it all the time on contraceptive pills. And looking back now, I thought, my God, you look at it back now and I think, well, of course, it's the hormones. It's changed the structure because contraceptive pills can block the effect of these hormones that are having down in the local area. And we just don't associate bladder and weeing with our hormones, I think. And so it's trying to get that whole understanding. I think it's easier to think of dry vagina and sex to do with our hormones, but not bladder. And so, yeah, interstitial cystitis, it can be caused by this. Like I said, after you've had a baby, if you're breastfeeding, that also brings your estrogen down very low. But the interesting thing is there's genetic changes as well as how you present with genitourinary symptoms of menopause. I'm just going to say GSM from now on. Probably should be perimenopause, because like I said, until you get the architecture change, which is late postmenopausal, preceding that, you're getting the feelings, the sensations. And we should all be thinking, okay, well, let me try a trial of estrogen. And I think for me, because I've just done a 3-month trial of vaginal estrogen. As you know, I did trials of topical estrogen, and I'll be doing a trial of testosterone as well, and we'll be doing a live on that. But when I used to prescribe systemic HRT, I used to say, have you got vaginal symptoms? No, it's fine. And I used to say, okay, fine. And I used to tell them it can take up to, 3 months for the systemic estrogen to reach to your vulva and vagina. And it was only when I started, probably last year, a year ago, I started co-prescribing it. And the biggest thing when I brought them back at 3 months, obviously if they said that they had it, that would be a definite, I'd be prescribing it. But I started realizing that women coming back after 3 months, whether one of the biggest change they'd noticed after being on systemic estrogen and the vaginal is they're like, God, I didn't realize how dry I was. I didn't realize that actually that thrush feeling that I get sometimes when I go to the gym, or I, that I getting up in the night, going to the toilet, or any of those, they had never put the 2 and 2 together. And even sex, they said, God, it wasn't really that uncomfortable, but boy, is it much more comfortable now.
So prophylactically, are you then thinking that, once we sort of hit perimenopause, that, perhaps as a prophylactic measure, it's as a preventative measure?
Preventative, and that's the key word, is because we know that this is chronic, because we know it's progressive, that means it only gets worse. And we know that at a later date, years down the line, you're getting, because the tissues have not had estrogen, for example, you get these atrophic changes. It starts shriveling back. The look, the anatomy, the architecture, what we call of the vulva and the bladder actually change. They shrivel up. The labia minora actually start to disappear as they were, like I said, prepubescent. Where the urethra, it comes out into the vulva, all that tissue around there, that changes, and that only gets chronically worse. So I can't think of a good reason as to why we wouldn't. And so that has changed my practice, instead of waiting for postmenopausal or even them to come forward with a complaint of one of those symptoms, I will be, actively prescribing it and suggesting it. And they can then say, actually, do you know what, in 3 months, it doesn't make any difference. But most of them, it has made a difference. And you continue on it for life. You go to it with your grave. So yes, I would. Why wait until you get those anatomical changes?
Absolutely. Question here for you.
Point.
Question: what about dryness and lichen sclerosis? Would you recommend using vaginal estrogen to help with this?
So if you've got a diagnosis, then there's no concern with that. And you might, yes, but you've also got to be using your steroid cream or your other regime that in terms of treatment. But yes, because it's giving that lubrication back. But I wouldn't be using it if it's not to do with hormones. So if you've been diagnosed that in your 30s and the symptoms that you're getting because of that is not to do with lack of estrogen, I'd be using your treatment. But yes, after 50, if you're not on any other HRT, we know that you're going to be lacking estrogen. So yes. And if you haven't got a diagnosis and you're just itching and you keep teaching yourself a thrush down there, go and have someone have a look. We need to look to just because there are, again, with lichen sclerosus, there are architectural changes again where there's fusion of the clitoris and the labia minora. So we do need to check on that. But yes, essentially,
Yeah.
you can use it once you've got your diagnosis, and we're making sure we're sort of treating the right condition.
Yeah, and just so people know, the labia minora. So if you're looking at a vulva, you've got sort of.
We need our angels, Fiona. We need woolly angels. But yes, the labia minora are the two big lips. The labia majora are the two big lips that you always have. And then as you go through puberty, these little ones or big ones, depending on what your anatomy is like and what your genetics are like, they protrude in between. And then you've got the clitoral hood with the clitoris in the middle, and that's and then the vagina hole down here, the vulva, and what they call the vestibule, which is sort of a little bit of tissue that goes around the urethra and above the actual vaginal hole. That's called and that's actually contains a lot of bladder tissue and responds very well to estrogen and testosterone.
Interesting stuff. There you go. And it is important that we call them the right things, isn't it, really, rather than, because otherwise if I come to you and go, my foo-foo's sore, you're going to be wondering exactly which bit of me actually is sore.
Exactly. So, exactly. And it's a term that, yeah, I feel quite strongly about children calling it the right term, but I mean, I call it vulva and vagina I've got two boys who are 10 and 6, and they've known from the very beginning what the anatomical words, but they still come home with foo-foo and, other new, all these other words that the girls in their class are calling it, and that's fine. It's just, I don't think they need to go into too much detail now. But I think it's important we get the anatomy right. I remember my son, it just reminds me of my son, a little girl in his swimming class held her legs up in the splits, and he said, "What's that tongue that comes out of her foo-foo? It kind of came out." And I said, "I thought, do I say the clitoris or what? But I had to. I was like, that's the clitoris." And honestly, he was so bored. He was like, "Oh, okay, fine, that's it." And so he wasn't very interested, but he just wanted to know what it was. Was it a tongue? I was like, no. But it is important because there are certain bits, of your vulva that will, the clitoral hood will shrink, and then it exposes the urethra and the clitoris, and it can be extremely sore. And you've got this urethra protruding. You can get urethra, which is the wee pipe. You can get a little prolapse of that. And remember, when we've got vaginal prolapses because of childbirth or whatever reason, obesity or something bearing down on it, vaginal estrogen is your friend, because that lubricates it all again and takes it back to that elasticity and helps that.
Shall we talk then about the different types and why some might be better for some people, or some, some types of conditions, what's the sort of risks of, actually, before we get to the different types, is there any risk with using vaginal estrogen? Because I remember going to the GP once and she sat there literally adding up how many milligrams of Sandrina I was on, then adding up the
Oh my gosh.
Yeah, I know. I was just looking at it going, seriously, stop. But it made me think that some people still think that there's a risk in using vaginal estrogen. Is that the case in are there, for the majority of people, is it absolutely fine? Is there anybody who is not necessarily fine for?
So short answer, it's very, 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 very safe. And I think that's what we need to get across. So what does vaginal estrogen do? If we think back to those three main things that it does when it's taken away, it increases the elasticity of the vagina and all of the tissues around that area in the pelvis, the bladder. And so therefore in the vagina, it makes it more stretchy and more, comfortable to have sex. And in the bladder, it reduces that overactivity of wanting to go to the loo all the time. It increases the cells producing the lubrication. So it goes back to producing lubrication again, therefore obviously making sex more comfortable, therefore and restoring the pH. So it restores the pH and it keeps those bugs away, because obviously the vagina's got its own microbiome. And so therefore you're not going to have thrush or urine infections so much. Just a word on that before we go into yes, it's safe. Oh gosh, my Mac's about to die. Oh gosh.
Don't die, Mac.
Gosh, I didn't think of this. But in terms of I think it'll be okay for a minute. So what I was going to say, it's
Safety.
Yes, so safety, yes, it is safe. Because the estrogen that you put there, it's such a low dose that if you, this is a really easy way to remember it, is that if you put on, it takes a year of vaginal estrogen is the equivalent of one oral dose of estrogen. So the amount that goes into the bloodstream is so small that it's almost like negligible. And it is, I'm just worried about my computer now. Let me just see how many it's a little bit. It's okay. I'll go on my own if not. But it's so negligible, it's not picked up in the bloodstream. So therefore, it's safe for those that even have had a history of breast cancer and or any other vaginal or gynecological cancers. And it doesn't have to have a progesterone with it. So if you have systemic estrogen, you have to obviously protect the endometrial lining by taking a progesterone as well. So it doesn't have to take that. The unfortunate thing is that when you get your vaginal estrogen, I was going to show you that there are warnings all over the place in these leaflets that basically tell you you're going to have strokes and heart attacks and risk of breast cancer and bleeding and thickening, because it compares it to the normal systemic estrogens. So and even those, if they're body identical, has limited risk. So I'm not going to go there with that. But the leaflets are really off-putting to those that read leaflets and think, oh my God, what has my GP given me? And until you're really educated yourself and you read all the literature and you realize what's happening now in terms of this movement towards, vaginal estrogen as a preventative measure, even as a clinician, you're going to be like your doctor, adding up all the doses, thinking, oh my goodness, is this going to harm my patient? So yes, it is very safe. And there are lots of different types of it. And I mean, if we could just dip into very, very slightly about how safe it is and how it could prevent urine infections going forward, because thrush doesn't kill. Okay, it's very uncomfortable. It's and painful sex doesn't kill. It might kill your relationship, and to be fair, that's a really good point to make, because people don't become sexually active and the relationship dies, unfortunately. So yes, it's got. If we think of the consequences of not treating it, very uncomfortable group of women, very sore, really reduced quality of life, relationship issues, but the urine infection is astounding. Now, as a GP, I'm completely put my hands up to this. I spend a lot of my time, or have done in the past 20 years of being a GP, prescribing antibiotic after antibiotic for those over 50, women. That doesn't treat the root cause. Two, there's so much antibiotic resistant now. I used to, treat with trimethoprim when we were 20 years ago, and now first line, because so many people are resistant to trimethoprim. It's now nitrofurantoin. 1 in 4 women are resistant to one antibiotic or another for urine infections. And it can involve hospital admissions, sepsis, and it can even kill in older women. So and the symptoms don't present in the same way as a young woman. So a young woman will have
that now, I think it's around the mortality rate is somewhere around, I think 7 to 12% or something. It's quite high. It kills quite a lot of people.
Oh yeah, it can do, because of the sepsis. So once it's gone into sepsis, so if we and the hospital admissions and the toing and froing from GPs and the sending off of urine samples, And what I was going to say is it won't present in the same way as a young person. So we used to call it, or it's got a name called off legs, which means that when you're, you know, elderly person, we just get the relatives or the carers ringing up, oh yeah, you know, she's gone a bit doolally again. And that's how it presents when you're older, because it's gone, it doesn't have that typical burning, or they might be non-verbal, or they're not being able to describe what they're, that typical sensation of a urine infection. And so, you know, and actually there is a paper I was reading before this that increase in urine infections can actually increase dementia. So, you know, there's just so many reasons why giving vaginal estrogen, which is extremely safe, which is what the tissues just want back. Because remember, you know, we didn't have this hundreds of years ago because people didn't really live that much, you know, longer after their menopause. So this is just so important now. Even, you know, even I feel really bad, like my poor mother. I've just thought, oh gosh, and I remember my grandmother going in and out of hospital with infection after infection, and just loading her with antibiotics. And you've got to remember that these urine infections, if you're feeling a bit doolally, and if you are needing to get, because overactive bladder doesn't necessarily mean a urine infection, it just means that you're needing to, you increase frequency in urine, you're getting up in the nights, oh, you're a bit doddery, you trip, you fall, you break your hip, and then we know that's a serious condition and can be fatal as well. So there are so many bad things.
Reasons for not having a urinary tract infection.
Sorry?
So many good reasons for not having urinary tract
infection. And plus, it's bloody uncomfortable. If you've ever had one, my God, it's absolutely excruciating. So,
so I remember somebody actually once years ago when I was in New York and I got one, and I had to
get my charger while I'm listening to you.
Yes. And so I went to an extremely expensive doctor in New York, and they said, "What makes you think you've got a urinary tract infection?" It's sort of like, dude, I've had one of these before. This is unmistakable. Once you've had one, you know what it is. You really do. But I think one of the studies that came out recently while you're plugging in, well, not so recently, but a while ago, was showing that if you used vaginal estrogen, there was about more than 50%, 53 to 55%, I think, decrease in the number of UTIs, in the recurrences. So it was a big reduction. Yeah. Yeah, it didn't work for everybody, but it worked for more than half.
Exactly. And when you take in all the other factors that might have, you know, aided that, then yes, it's been shown that it helps. And, you know, I think everyone's on the same page when they say, well, why not do a trial? It's the same with all of these things. If you know that it's a safe medication, it's not going to do any harm, do a trial first. I would say to anyone, if they are not sure, but they're thinking, oh gosh, that sounds a bit like me. I'm 43. I was, you know, it's a bit early. I didn't think that this would be me at this point. I'm getting a couple of urine infections, or, you know, I'm feeling a bit yeasty every now and then, a little bit more than I used to. Particularly if it's possibly around your cycle and it's a couple of days before your period, try a trial of vaginal estrogen. You know, you will know. And
two questions here for you. Just to one is I'll ask this one first, then Kathy, I'll come back to yours, because this one is slightly more related to what we're talking about. Can the vaginal estrogen cream cause a burning sensation if you are extremely dry?
Yeah. So yes, it can. So we can go on to different types. And so there are pessaries and there are creams. And so creams can be, just in general, and we can go a little bit more, Fiona, after this, but just in general, a pessary is very small. It goes high up, and it doesn't really lubricate around the area. So if you felt that you were going to be particularly sensitive to that, then I would do the little tiny pessaries. I was really surprised about how small they were, because I've been doing a trial, and you won't really feel any sort of vulval symptoms because it's not a cream. But some people feel relief of the cream because it's so dry and irritating that then that's moisturizing. But with both of these, usually there's something called a loading dose. So a loading dose would mean you apply every day for 2 to 3 weeks. Remember, you can't really overdo this. So 2 to 3 weeks, let's not get caught up in numbers and days. And then there's a maintenance. So once you've kind of done your loading dose, you go on to a maintenance. A couple of times a week, you're putting a pessary up or putting some cream in. And it's been shown that in those first couple of weeks, if you do a loading dose, a tiny, you can get a little systemic peak. So in your blood, it does show a tiny peak. And when we say that, why is that important? Because then you might have some side effects of estrogen. So a little bit of a tender breast or a little bit of a headache. And if you're very estrogen sensitive, you might notice that. So, and then if you're doing it every day and your little, your poor little dry vagina hasn't had any estrogen for ages, when you put vaginal estrogen suddenly every day onto it, yes, it could find a little bit irritated. But that's why you get that slight peak, because one, you're applying it every day, but two, a dry vagina is going to soak up more of this lubricating cream than a nice, plump, protected, lubricated vulva and vagina.
True.
Now, no reason to have that loading dose. It's just that you may notice that, and that's fine. You can just go to twice a week instantly if you're finding an issue.
You mentioned prolapses earlier a little bit, and the question is here, can a lack of estrogen contribute to a prolapse?
Yes, because it involves all of the tissues around that area. It that elasticity, that collagen, is affected by lack of estrogen and testosterone. And so therefore what's holding it all up is the collagen, the bounciness, these are tissues that are constantly being used, constantly being stretched, the bladder, going for a wee, going to the, around your rectum, around your vagina, everything's being stretched and used. It's not static. So, even if you gave birth 20 years ago, those tissues are now starting to show, because of the dryness, they're starting to drop and not be held up so much. So yes, definitely.
There you go. The joys was the answer. Right. Types. Shall we have a little look at the types then? So I can get my estrogen out at you again.
Yes, you can.
Which one do you want to start with?
So in general, because I'm actually going to do, I've actually been drawing out a table for myself, which once I learn how to, not learn, once I create it on a nice little table, I will post it to my Instagram account.
You mean it doesn't look like you?
It's a bit similar actually, but essentially you've got estradiol and estriol. Estriol is a slightly weaker estrogen, but I wouldn't go by what's stronger and what's weaker really necessarily. It's more about because people respond slightly differently anyway. But I would more go on what you would tolerate. So there are tablets, and when you say tablet, it's a pessary. And when I used to think of pessary, I used to think, God, they've got to shove up something huge. And that's not the case. This is, there are 3 different types with the sort of pessary in general of what people have probably heard of. That's Vagifem. It's estradiol. There's Vagirox, which also estradiol. It's exactly the same. It's just got one applicator, which you have to wash between applications, whereas the Vagifem is a bit overly use of plastic, which I don't like. Yeah. And so an applicator for each one. And if you think of how many applicators you're going to be using for the rest of your life, I'm not keen on that really. And then there's Gina, which you may have heard is over the counter, but still, this is a lifelong as progressive. So why buy over the counter? I mean, yes, it's an emergency or on holiday or whatever. Let me go and get my Gina. But otherwise, you really should be asking your doctor. So this can be indefinitely prescribed. And essentially the little pessary, I mean, it is tiny. I've actually used on mine, but it is about, I think I saw it was 6 millimeters across. It's tiny. It goes in the end of your applicator and you push it up as far as you can go and you release it. And to be honest, you can't feel it because it's so small. That's suitable for someone that doesn't really have any urethra or pain around the clitoris or any obvious signs of drying, I would say. because they don't need that moisturizing feel, and that's suitable to get going with, and that will release all of the estrogen in all of those local areas. And there's three different types, like I've said. The other one,
size of a Tic Tac, Trish is saying over here.
Oh, it's smaller than a Tic Tac. Honestly, I thought it looks like the size of an antihistamine. It's tiny, almost to the point where I thought, God, if I was...
That's my go-to comparator of the antihistamine.
So much so that I thought I had them with me, and I picked up an antihistamine. So that's how small they are. So the other thing is, I did think if I had sight problems, or fingers, or arthritis or something like that, I think they're so small that you could drop them. So that's fine. But if you have no dexterity problems, it's a great starting point. The vaginal creams are more for, but they don't have to be, is if you've, again, they often come with an applicator, and I tried estriol cream. So if you can, well, where's the applicator? Again, you're meant to sort of pull it up through there and squidge it out. It's very messy. That's sort of the cream. It's like a sort of moisturizer. It's fine. I didn't particularly have lots of, I'm just going to rub it in my hands now. Lots of vulval symptoms, because I've been on systemic HRT, like I've said, for 8 months now. So I don't get that menstrual burning and itching. But so I found it quite messy. But that's fine. But if you have got sore around when you go for a wee, or you've got an itching on the vulva itself, this can be quite comforting to have a cream. There's another one called Blissel. So the Ovestin cream and the estriol cream, like I've just said, the estriol cream are both creams, and they come with an applicator, and you can wash the applicator and pop it in, and do whatever you want with this in terms of, it can go up inside the vagina, and then you can put it all over your vulva. There's another one, where they call it a gel, which is Blissel. And this is very low dose. It's water based, because with the creams, it can affect condoms. So if you are in your perimenopause and using condoms, I mean, to be honest, you could sort of schedule it so you're not using the cream at the same time as condom sex, but it's just something to be aware of. But Blissel is aqueous, so it's a bit more gel-like, and people tolerate it a little bit better if you're someone that doesn't like all of that creamy feeling. It's
which I can tell from the look on your face. You're not.
Well, it was just like you sort of wake up in the morning and it comes out a lot. But then also Blissel does come out.
I don't have that problem at all. I find it actually sort of. I mean, it's a bit annoying to have to clean the applicator.
Yeah.
But generally, I don't really find it all that messy.
Yeah. So that's what I'm saying. So it's everyone's slightly different, and your symptoms are probably slightly different from my symptoms.
Oh, yeah.
And then there is, but that's quite good for those with breast cancer, because that Blissel, because it's an extremely low dose, and that's a very low dose. Then there is something called Invagis, which is like truly what I imagine a pessary to look like, which is a great big waxy pessary, and you don't have an applicator, so environmentally friendly if you're thinking like that, and you need to insert it yourself into the vagina, and you do that at night, because if you do it through the day, you'll probably start feeling it coming out. But what women do like about it is that it melts. It sort of melts overnight and gives us a real moisturizing. So although you're not putting the cream everywhere, you've got this big pessary that's melting inside your body. And remember, it's still only twice a week, and that might be easier if you can't find the little pessary to put on the applicator and you're not very dexterous, and you can just pop it into your vagina at night. So that's another good one. And then I was going to talk about the ring, but I don't know if you want me to talk about Interosa, which is the DHA EA cream. I'll talk about the ring first, because I know you're very keen to show off your ring. And then there's the ring, which is, again, it's a slow release of the estradiol. And the great thing about that is that you'd have to change it every 90 days, so every 3 months. And of course, for those that forget, or it's just very low maintenance. However, passing over to you, Fiona, you've got experience of it, and I was asking you questions on, do you fit it yourself? How did you work that out? Because obviously, if you've got an old lady in a home or anything, they're probably not going to do it for them, and it's about something that it's about finding something that's compatible with you. But what I found interesting, what we discussed before, is that because you can't get hold of yours, some of your symptoms come back, and what you found with the estrogen e-string, the actual ring, is that they went within a few days, despite it not being a cream and acting locally. That's because it is known as a slightly higher dose that's being released continuously.
Yeah, I think that constant release is probably a very good thing. So basically what happened to me was I was using Avestin for years, and I started to notice that sort of burning was coming back. There was this slight feeling around the opening of the urethra, and I thought, oh, am I getting a urinary tract infection or something like that? Just slight burning. So I thought, you know what, I will. It was Juliet Balfour who'd been saying to me for years, you need to get one of these, you need to get one of these. And so I thought, well, I will try it. And literally within about 24 hours, that burning feeling was gone. And the feeling like I was getting a UTI was gone as well. So I'm really missing it now, because 2 months since I've had it, and they are back with a vengeance, which is not a lot of fun. It can be a bit of it. I mean, I know it looks huge, but it's not really that big. And hang on, where's the thing? And to get it in, you just you give it a bit of a twist and sort of slide it on up. Getting it out can be fun. It can be an interesting thing. I found lying on your back is the easiest thing to do. I've had legs on baths, I've had legs on kitchen benches, I've had husbands having to do it, I've had to have a GP having to do it. But I have found that I can manage it quite well if I'm lying on my back. So
okay. So yeah, I mean, I think would you say that you'd have to be quite dexterous to use it?
Yes. If you had difficulty reaching down there, then you've got to have a certain amount of dexterity.
Yeah. Okay. And okay, because I think that is something and as we know that there's a shortage at the moment. So once it's back in, I think we'll have another shortage, because everyone will be going and trying to get months worth of these
Exactly.
strings.
And the other thing too, though, is if you have one of these and your pharmacist says to you, oh, why don't you just swap it for a NuvaRing? You cannot swap it for a NuvaRing. It is not a contraceptive. This one is HRT. The NuvaRing is a contraceptive. They are not interchangeable. This is why we need more pharmacists to do the Menopause Research and Education Fund training, because they are not interchangeable. So say no if that happens to you.
But it is good, because if you do need, so some people have a shelf pessary, and you can use the ring alongside that if you've got some woman, if you've got a GP fitting it for you. So that's another thing to say. So if you do have a woman going in, but it's every 3 months, which you might want to start learning doing it yourself, I think. And then there is the other one, so intrarosa. Because as I said before, there is not only estrogen receptors in the bladder and the opening to the urethra and the vagina, but there are also testosterone receptors. And so what intrarosa is another local vaginal estrogen, but it's called prasterone, which is DHEA, and that breaks down in the vagina to both estrogen and testosterone. So is actually a little bit, dare I say it, superior to vaginal estrogen. However, vaginal estrogen can do pretty much all of what we said. So, if someone's on vaginal estrogen, that's absolutely fine. You don't have to all go out and be going to get the DHEA or intrarosa, but it's the only product on the market that does both. And so what I would say is, if you are still having issues of the burning nature of or the reason why you went on vaginal estrogen in the first place, well, first of all, go and see if you haven't got another infection on top of it, or a condition like lichen sclerosis, but then ask for a trial of intrarosa, because some people respond much better with testosterone. As we know, with systemic testosterone, it doesn't work for everyone, and it's not certainly part of the guidance where you have to go on it, but it's something worth considering. And so this would, and it seems to be much better with bladder problems and UTIs, because there are a lot of testosterone receptors around that area. So yeah, try the vaginal estrogen. Make sure and you can use it more than once. Remember, the vaginal estrogen, it doesn't cross the barrier. It doesn't go into the bloodstream really. So if you're saying, oh, actually, it's great, but I want to go up to 2 or 3, 4 times a week, fine, you can do that. It's that safe. So there's that one to talk about, and then another one that we slightly touched on, Fiona, is the SERM. So I can never pronounce it correctly, but it's what's it called?
Ospemifene.
Ospemifene. That's right. So ospemifene is
dyslexia. It took me a very long time to get on top of that.
Yeah. But this acts like, in very brief, it acts like an estrogen in that local area, and it's very good for something like what we call dyspareunia, where it's pain during sex. And if you can't take a cream or a tablet into the vagina, or you can't put it in, it is a tablet by mouth. And so it's often recommended for those that are breast cancer survivors as well. And there's no need to replace there's again no need to have a progesterone alongside it, but that's something other to consider. But it's a little bit underused, but whereas local is probably used more and it is more effective, and we've got lots of different options. So I would probably be looking for one of those unless you really couldn't tolerate a local preparation.
Yes, absolutely. So I'm just looking at to see if that's a question there, but I can't really read it.
I did have a couple of questions. So that people had mentioned to me on Instagram. So I had, should everyone be on it? To me, I don't know what you think, Fiona, but pretty much yes. I think if you're after, if it should be going home in your, I've turned 50, if not before, a party bag from your GP health check, because I think with everything, prevention is better than cure. And why do we have to wait until everything's sort of shriveled up and you're going into a hospital multiple times before you start using this? And the other question, and that goes for women who are younger, who are on contraceptive pills, who are getting these symptoms, or that, like I said, postnatal breastfeeding, try trial. It's not dangerous. It's not going to adversely affect you. Can it affect my partner? So the answer is probably no, because, well, their answer is no. If it doesn't cross our, mucosal membrane to go into our bloodstream, then why would it do theirs? I'd probably not. I mean, you don't use it as a lubricant. So probably separate those two events out, inserting your cream and having sex. But there's no reason why you can't have sex when it's in your vagina. And then, do you need to check your estrogen levels? No, like we said, because the levels do not change.
Well, I guess the other side of that then is if you have had them checked and your doctor has told you your levels are all right, these are the sorts of things that, that, as you know, these are the things that I hear all the time. I went to my doctor and we tested the levels and he said I couldn't have HRT because my levels were within normal levels, but I've got all of these symptoms. Would they be, if they come back and you say, well, I've got these vaginal ones, can I have the vaginal one?
You don't need to check it before or after or anything. That people shouldn't even be having their estrogen levels really checked before they even initiate. That that's not one of the criteria to start systemic HRT, because as we know, if you're pretty much over 45, I'd argue almost over 40, but over 45, have symptoms, trial of estrogen, with or without progesterone.
And whack that in as well. Question here for you. I think this is about the ospemifene. Would that be the best for an elderly patient if given vaginal estrogen is difficult to administer?
It would. Would that be the best? I don't know two different trials. I don't. I would always just say, have a trial and see. If someone's not going to be able to put that for an elderly person down there, or that they couldn't do it themselves. You know, the Invagis pessary is actually quite good for an elderly person because it's twice a week and it's just on the entrance. You could just about get away with it, and it gives that moisturizing effect, so you don't need to fiddle around with applicators. And like I say, a ring, like you were talking about, a patient who had a mother in a care home and used to, did she change it herself, or, but you
No,
know,
obviously not, because why didn't, while the last one wasn't removed for a long period of time.
Yeah. So
then if you are having that one, somebody has to remember to come and take it out and change it for you.
So yes, why not? It's if they're really not going to tolerate the creams or the pessaries or the little tablets, then give it a trial of that.
Yeah, gosh, it's such a insidious too. I mean, it sort of creeps up on you. You don't really sort of necessarily notice how, these sort of little things when they're changing. I mean, as you said, like when you gave it to the patients anyway. I mean, it's interesting how your practice has changed in where you're now sort of going, have this and have this with it, and how they came back afterwards, not thinking that they had those problems until they had the treatment, and then realized that they were actually so much better.
But it's the same with me. So this is so I because I like to do everything separately, because I want to see what effect, and because I was discussing it, sort of in my Instagram account about how HRT might have affected me. I didn't want to try it together, so I started trying vaginal estrogen. I'm not really thinking, oh, dry vagina. I don't really have those typical symptoms, but I have not had one issue thinking, oh, I've got thrush again, or because a lot of people will be wearing, their activewear, they're trying to get fit, and that causes a lot of thrush. And I haven't had any of that symptoms of, when maybe I would have done. I've got a Mirena coil in myself, so I don't have regular periods now. But the HRT systemically did take away that burning and cyclical pain and itch. But the vaginal estrogen itself has just made it more comfortable. I'm no, I did a little reel today of just someone just trying to scratch it. I mean, everyone has been there when they suddenly get this out of nowhere awful itch, and you're just thinking, oh my God. It happens to everyone. And I have changed my practice now I pretty much tell everyone every day how to wash their vulva and not wash their vagina, and only using water. I mean, it's pretty much an everyday statement that I say. But now, if it's been going on for a while, no matter how old they are, if they've been told that they've got interstitial cystitis in their life, I would now feel comfortable to say, look, this is the evidence about this. Don't be scared of the leaflet. Have you tried this? Because they don't want to keep going on these antibiotics. Do you want to do a trial? And so that's what's changed my practice.
Yeah, I think I have a new menopause symptom for you, actually.
Oh God, what is it?
While we're on itchy groins and those sorts of things, not a hot sweat, but massive sweating in the groin. And I put this to my vagina group, actually, because I have the private group for vulval vaginal issues on Facebook, and said, does anybody else experiencing this? And I had quite a few people coming back and going, yes, at night. Just started out of nowhere, non-stop sweating just around the groin.
Oh wow! And that's with vaginal estrogen and HRT, or okay?
Yeah.
So your vagina is having hot sweats too.
On its own, just localized.
Maybe it's taking
get any better.
It's coming out there. I haven't experienced that, and I haven't. It's not been a
Something to look
question
forward
I've
to.
asked. Maybe we need to. Well, how many symptoms are there now? 51. We need to make it 52 now. Well, I can't remember how many symptoms there are, but there's so many, aren't there?
Sure.
So okay. But I tell you what it will do is it'll save you money, going to get the antibiotics, saving you time, saving you going to get the thrush cream. I mean, I've not had to stock, thrush cream or Canesten or whatever, just in case, as a kind of preventative, as I sort of feel it, well, at all. It's not been required. So, and I'll always tell women, oh, just have a, have a little tube of Canesten, because when you feel it coming on, you know, better get onto it then, rather than letting it get it worse. But it takes away all of those mild and silly irritations, without any other change in my life. So yeah, it saves money. It prevents your vagina becoming atrophied, your bladder becoming atrophied, prevents infections for the future. And so that's how we should see it, really. It's a prevention medication that's extremely safe and very cheap.
Yep, exactly. Brilliant. Is there anything else that we need to cover? Do you think we've
I was just looking at other questions. I think I've gone through everything. The other thing I would say is that I often get, so it's much better with women on these vaginal estrogens, but that's not to say that that's instead of a lubricant or a moisturizer. So often these things go hand in hand, and some people, even if they're not having, I'm not talking about just for sex, obviously, that, you know, you might bring in a lubricant or a moisturizer for that, but just in terms of a moisturizer in day-to-day wear, where people can just actually start wearing knickers again, and feeling comfortable, you know, sitting down at a desk, they might need their vaginal estrogen and their moisturizer. And that's
actually do a whole one on moisturizers, actually, because that's a whole other moisturizers and lubes. That's a whole topic in itself, pHs and osmolalities and all of those sorts of things.
Yeah, yeah, exactly. And the microbiome, and I mean, yeah, all of these. I mean, I just think back and think of how many people I've probably treated with thrush cream years ago, I'm talking about, and they probably just needed a bit of vaginal estrogen. So I think all of us doctors have done, you know, have probably not practiced as well as we could have done if only we'd known. And so yes, let's change the narrative, as they like to say, going forward. And so if anyone hears of anyone with a recurrent urine infection, or has a sister or a mother or a grandmother or an aunt or a best friend, then tell them, go along, have a trial of vaginal estrogen for 3 months and see if it makes a difference. That would be my go home. The Gina is one of the tablets, the tiny little tablets. It is available over the counter, but it's only available with certain criteria. It's still £30 for 1 month, and it's, you know, 1 or 2 months. And you've got to be over 50, postmenopausal, you know, lots of people, these are happening in perimenopause. So, and you want to be on it forever. So it might be a starting point if you're desperate, but I'd be going along and advocating for yourself, because that's the other thing. People are sort of gaslit into thinking just put up with a bit of a dry vagina, and it's not. So, and just put up with a urine infection, or just put up with, you know, you pick up infections after you've had sex. So, you know, wash yourself afterwards, drink lots of water, urinate after sex. That's what we, you know, that's the old advice, and it still continues. But it's not changing the cause of what's initially causing these symptoms. So that's what I would say. Don't let your doctor tell you that you're not suffering.
Yes, or making you feel that it's your fault because you're unhygienic.
Oh yeah, well, yeah, exactly. Or you're not washing properly, and you're not going for a wee, and you're trying various positions, and you're, you know. So I've heard it all. But yes, a trial of estrogen will make your vagina much more healthy, so you can go and do all these things that you're used to.
Last question here. Could the cream cause period or endometriosis-like pain in postmenopause?
Endometriosis, I mean, severe pain. I mean, it's
like.
Sorry?
Endometriosis-like, she has said.
I guess, if, to be honest, I don't know, and I don't think there's enough studied on it. Endometriosis is tissue which responds to estrogen in the pelvic area. I have endometriosis myself, and you know, there are certain little bits of tissue around that area. I personally haven't noticed it myself, but it depends where that tissue is. It doesn't go into the bloodstream, but it will affect all of the tissues around it. So maybe try a different preparation, or try one of the lower doses if you're finding that, like Blissel. And because I think you've got to always weigh up benefit and harm. If the pain is that bad that you're feeling that it's going to prevent you from using it, versus can I have sex tonight, or am I getting my urine infections? There'll always be a little way around it in terms of using the lowest dose and, you know, maybe just putting it on the area that's sore, like the urethral opening, for example. So, but I wouldn't cause it to completely stop. I would just go and have a discussion with your GP and
That
find
makes
something that
sense.
suits you.
Brilliant. So speaking of GPs, where do people find you should they wish to find you?
So I work privately at the London General Practice, and I have my own little Instagram account where I'm trying to educate when I have time in between patients.
Since people can only see that on that, what is your Instagram handle? I should know that.
Dr. Elise Dallas.
That's right. That's quite simple, as it says on
Yeah,
the tin.
yeah, it's yeah. So and I'm just recording my own journey of going through menopause as well, called Dr. Dallas Does Menopause. So
Absolutely.
trying out all these products.
Brilliant. All right, lovely. I will let you go because we're up to the hour, so I shall end this here and then end it on Instagram. Thank you again, and we will speak soon. Take care.
Brilliant.